Hi, everyone. My name is Kathleen Schmeler. I'm a gynecologic oncologist at MD Anderson in Houston. While I'm waiting for my slides, I just want to say that I've been at MD Anderson for almost 15 years now, 4 years as a fellow and almost 11 as a faculty member. And Project ECHO is probably the simplest thing that I've done in my time there, clearly the most cost-effective. And probably the most impactful. And in all the talks this morning about burnout, I think it also has really helped me as I go through my career and many of my colleagues in avoiding or counteracting the burnout we all face. So Project ECHO stands for Extension for Community Healthcare Outcomes. It was actually developed by Dr. Sanjeev Arora, a gastroenterologist, a hepatitis C specialist at the University of New Mexico. And in this quote, he says, in the US and around the world, people are not getting access to the specialty care they need when they need it for complex and treatable conditions. So he started Project ECHO with a goal to really demonopolize knowledge from the big academic centers to the communities. He started the program to address the hepatitis C crisis in New Mexico. So patients in rural areas were unable to travel to the university clinics, primarily the University of New Mexico, for the hepatitis C care that they needed. Community providers were not comfortable treating hepatitis C. At that time, the drugs being used were almost similar to chemotherapy with a lot of side effects. So what he did is he identified primary care providers and advanced practice providers from 16 rural clinics and 5 prisons, and he started a telementoring program. And really just, using similar to what we do as trainees, where just doing case-based learning and reviewing cases with the providers at these rural clinics and prisons. He compared the outcomes between the patients who came to the University of New Mexico with these rural clinics and prisons where the primary care docs and APPs were working. And he saw no difference in cure rates and no difference in adverse events. He published this in the New England Journal of Medicine in 2011, which gained a lot of traction for the model. And really, it's a hub and spoke model, with the hub being the academic center and the spokes being the community clinics, mostly medically underserved clinics in different areas. And importantly, what he saw was obviously it really improved patient satisfaction to be treated close to home by providers that they knew and were comfortable with. But it also really improved physician and provider self-efficacy and enjoyment in their work by now being able to take care of these patients. So really, it's different from telemedicine. Telemedicine is where the provider is actually treating the patient at a distance, but instead this is more a telementoring program with provider-to-provider mentoring, with the idea of having a force multiplier in building capacity. So the format is quite simple. They're 1-hour video conferences, weekly, monthly, at regular intervals. We use Zoom, which is very similar to Skype. You can see in the picture at the top, that's our team in a conference room at MD Anderson. And then on the bottom picture is all the different people calling in from different clinics. The partners from the community clinics present cases, history, exam findings, labs, treatment, challenges, sort of all the usual things we do in our clinics every day. And then feedback and guidance is provided by the specialists. Everything is de-identified, so we're not providing care for those patients, but instead working with their providers. So both groups work together to provide quality patient care. And then we finish the hour with a short didactic to complement the case presentations or on any topic related to the ECHO that we're doing. And for our U.S. programs, we also provide continuing medical education credits and continuing nursing education credits. And again, this is telementoring, which is a little bit different from telemedicine. So the first program we started at MD Anderson was for cervical cancer prevention along the Texas-Mexico border in the Rio Grande Valley, which now I think almost everyone is familiar with that region. It's a population of about 1.3 million, primarily Hispanic. very medically underserved, with 40% fewer doctors and nurses than the rest of the state. And we don't do very well as a state. There are very few providers performing colposcopy and LEAP, which are some of the treatments of pre-cancerous lesions for cervical cancer. The cervical cancer rates in this region are 30% higher than the rest of Texas and about 50% higher than the rest of the country. And so we partnered with 2 federally qualified health centers as well as a mobile van to teach primarily nurse practitioners, nurse midwives, and physician assistants to screen for cervical cancer and to treat women with these pre-invasive lesions. We do hands-on training because you can't teach procedures by video conference, but we support the providers with video conferences every 2 weeks. We have about 22 participants per session, and it's really, we started in 2014. I didn't think it would still be going, and every other Friday when I walk in the room at 7:30, I'm always amazed at how many people have called in to present their cases and to learn from us and for us to learn from them. So we started the program, as I said, for cervical dysplasia or pre-cancer, but it's really grown at MD Anderson. We now have an echo for the early diagnosis of melanoma, for tobacco cessation, working with the mental health institutions around the state. We have a cancer survivorship program with family practice residencies in Texas. And then we do a lot of echoes for invasive cervical cancer treatment, mostly multidisciplinary, although some focused on radiation therapy, or on surgery. So we have one in Mozambique, Africa, that we hold in Portuguese. We have one for cervix, one for breast, one for head and neck, one for hematologic cancers, a radiation oncology one. Our palliative care colleagues run an excellent palliative care echo with 5 countries in Africa. And our pharmacy group has started their own echo. They've broken off from the other ones to really focus on issues related to pharmacists working with oncologists. We're the Echo Super Hub now for oncology at MD Anderson, so we train other groups to start their own echoes as well, if anyone is interested. So really the idea of echo is that it moves knowledge, not people, and that we can really take the best practices from many of the cancer centers and large academic institutions and get them out to the communities to really reduce disparities. I'll end there. Thank you.